very much. One, two. Right, okay. Before we start on the congenitally corrected transposition, let's just return to the normal heart for a moment, and let's reinforce the features that we use to determine the morphology of the chambers. So how do we know this is a morphologically right atrium? Because it has a morphologically right atrial appendage, and the pectinate muscles are running all the way around the atrioventricular junction, so they reach to the crux. In reality, we don't need to look at the shape of the appendage, although that's very useful. When we have the heart in our hands, as we do here, we can distinguish the atrial appendage on the extent of the pectinate muscles. As yet, in the clinical situation, there is no certainty that you can recognize the pectinate muscles, but when we were in Chennai last week, even in the fetal heart now, the resolution is becoming sufficiently great that you can begin to see these pectinate muscles with cross-sectional echocardiography. The new resolution, I am sure, is going to permit you to see the extent of the pectinate muscles and directly recognize the morphologically right atrium. What is certainly true is that you should be able to recognize the morphologically left atrium. You see, we concentrate again on the inferior aspect of the left atrium. And the inferior wall is entirely devoid of any trabeculations. Now, if I take my probe, I can pass the probe into the coronary sinus. Or at least I hope I can. So just for one moment, let me turn the heart round and let me look at it rather than show you what I'm doing. So there we are. So now I'm going to return to the... And there you see the coronary sinus has come all the way round the back of the left atrioventricular junction. So Snehal asked me yesterday, what is the significance of the coronary sinus? Not only is the left atrioventricular junction smooth-walled, it also has within its substance, as you see there, the cavity of the coronary sinus. And that is an amazing guide towards the fact that we're dealing with a morphologically left atrium. So the ventricles, we as morphologists are going to depend upon the apical trabeculations, and even not seeing the remainder of the ventricle, I can tell you those are coarsely trabeculated, and those are finely trabeculated and crisscrossing at the apex of the left ventricle. Of course, when we have the entirety of the ventricle, we're going to take note of that. So we know that this is the morphologically tricuspid valve because it has attachments to the ventricular septum, whereas this is the morphologically mitral valve because its attachments are to the parietal ventricular wall. And then when present, we'll also take note of the infundibular morphology, although that is much more variable. But when we find an infundibulum, we expect it to be morphologically right, because in most instances, the morphologically left ventricle has fibrous continuity between the leaflets of the atrioventricular valve, the arterial valve, in its roof. So those are the features we're going to be looking at now when we examine the hearts that are going to show us the features of congenitally corrected transposition. So here we have a very nice heart that is showing us classical congenitally corrected transposition. I don't need to open the atrium to tell you that is a morphologically right atrium. In fact, you can see the map of India upside down. And there the morphologically left atrial appendage. So we're dealing with usual atrial arrangement. But we want to be sure. So as I open that atrial appendage, you see the pectinate muscles that are running all the way around the atrioventricular junction. And I open inferiorly, and there you see the pectinate muscles extending all the way around to the coronary sinus. And we see that this is an obvious morphologically right atrium, coming into its roof, the superior caval vein, into its floor, the inferior caval vein, and on its septal surface, the rims of the oval fossa. And then beautifully there, we see how the morphologically right atrium is emptying through a morphologically mitral valve. You see that the attachments of the mitral valve are away from the septal surface. And here now, very nicely, you see this malalignment gap between the ventricular septum and the atrial septum. And it is that malalignment gap, the wedging of the mitral valve, as you see here, that is pushing the atrial septum away from the ventricular septum. This heart has intact septal structures. There's quite a large area there that is occupied by the membranous septum. Arising from the morphologically left ventricle is the bifurcating pulmonary valve. So here we see discordant atrioventricular connections combined with discordant ventriculo-arterial connections. We also see that in this particular patient, the aorta is anterior and leftward. So in this instance, we could describe the heart as having L transposition. But if Dr. Van Praagh was describing it, he would say it was transposition S for soletus, L for left-handed ventricular topology, and L for the location of the aorta. He would not simply say L transposition, he would say transposition S, L, L. So let's look in a little more detail at the anatomy of the left-sided chambers. And there you see very nicely the Ebstranoid malformation of the left atrioventricular valve. The left atrioventricular valve, of course, is morphologically tricuspid. There is the level of the atrioventricular junction, and we see there how the hinge line of the tricuspid valvular leaflet is rotationally displaced relative to the atrioventricular junction. And there's this diverticulum at the back here, which is the extent of the displacement, which is between the septal leaflet and the inferior leaflet of the valve, just as Kenneth Anderson described in the Mayo Clinic series. The valve itself is dysplastic. Then as we look anteriorly, we see very nicely the coarsely trabeculated, morphologically right ventricle. We can also see that there's a bit of an apical shelf here. I don't think that's particularly significant. Rather nicely here we see the multiple cords that are tethering the displaced septal leaflet to the ventricular septum. Here is the anterosuperior leaflet, and there the inferior leaflet. So focal attachment of the anterosuperior leaflet, and we don't have that abnormal connecting tongue between the anterosuperior leaflet and the inferior leaflet that was seen most frequently in the examples of Ebstein's malformation we were looking at this morning with concordant ventriculo-arterial connections. If we look at the septal surface of the ventricular mass, we see that it is my left hand that goes on the septal surface with my thumb in the tricuspid valve, my fingers up the outlet. The outlet is the aorta. When we look into the aorta, we see that these are the two sinuses that are adjacent to the pulmonary trunk. And there we see one valvular orifice that is arising from the right-handed sinus, sinus number 1. And in congenitally corrected transposition, that is going to give rise to the right coronary artery, which will encircle the mitral valvular orifice, and in this instance, continue crossing the crux to supply the diaphragmatic surface of the morphologically left ventricle. The other arterial trunk, which is arising from the left-handed sinus, sinus number 2, there you see its orifice, divides after a short main stem into a circumflex artery that runs in front of the pulmonary trunk. And there the circumflex artery is being cut across, and the anterior interventricular artery, which shows the plane of division, here it is, between the left-sided morphologically right ventricle, the right-sided morphologically left ventricle. The conduction axis is going to arise from an anterior atrioventricular node. And the anterior atrioventricular node will be positioned here, immediately beneath the mouth of the right atrial appendage. So the node is going to be there. It's going to penetrate through the area of aortic to mitral fibrous continuity, and then it's going to run in front of the subpulmonary outflow tract. And then the left bundle branch will ramify down the smooth superior component of the left-sided morphologically, the right-sided morphologically left ventricle. The right bundle branch will pass through and will emerge here on the right side beneath the medial papillary muscle. So here, very nice example, congenitally corrected transposition with intact septal structures. And almost certainly the problem here in this particular patient would have been the Ebstranoid malformation of the left atrioventricular valve. So a nice heart with which to start. So another one, you note that the ones I'm showing you thus far have all had the heart basically in the left-sided chest, in the left chest, apex of the heart pointing to the left, although dextrocardia is, right-sided heart is quite frequently in the setting of congenitally corrected transposition. We'll open the right-sided atrium in this instance and show you the extent of the pectinate muscles. No question, we're dealing with usual atrial arrangement. Mitral valve leading us into a morphologically left ventricle. Arising from the left ventricle, the pulmonary trunk. But this time, we have a much larger area occupied by the membranous septum. And in fact, this has got a tissue tag. It has got an aneurysm of the membranous septum. And during life, that aneurysm of the membranous septum would have blown into the subpulmonary outflow tract and would have produced subpulmonary obstruction. Now it's a flaccid structure, and it will go back into the left ventricle, and left-sided ventricle rather. And as you see, when we remove the aneurysm, the pulmonary valve is of very good dimensions. There's aortic to pulmonary fibrous continuity. The ventricular septum is intact. So almost certainly, during life, it was the presence of this aneurysmal membranous septum that was producing the subpulmonary stenosis and creating the clinical problems. If we look on the other side, we see that that isn't the only problem, because here we have a much more florid example of Ebstein's malformation. We also see that there is a supravalvar ridge in the left atrium. That is interesting. That is a supravalvar mitral ring. It's a little fibrous ring. It's above the orifice, in this instance, of the tricuspid valve, and you see that it's going all the way round. You see that the valve then, in fact, it is the septal leaflet of the tricuspid valve that is ballooning through and creating that tissue tag that's entering the left ventricular outflow tract. So not only is that tissue tag producing subpulmonary stenosis, it is also distorting the function of this morphologically tricuspid valve. Because in fact, the tricuspid valve is tethered at the atrioventricular junction. So I was wrong when I suggested to you that this had an Ebstranoid malformation. It is the fact that the septal leaflet has blocked that what would have been a channel between the ventricles, although I take back what I say now, because also there is further abnormality in the apical attachments of this valve, so I think there is also a degree of Ebstein's malformation. But a very interesting feature where the lesion of the left-sided tricuspid valve also produces the tissue tag in the right-sided outflow tract of the morphologically left ventricle. And we've been talking about the eye of faith to see the conduction system. And I think you can see the atrioventricular bundle as it descends here in front of this area of the tissue tag. There it is. It's come in front from here, the atrioventricular node. And there is the bundle descending. And then here we have the ramification of the left bundle branch. So another one, looking at the right-sided atrium, pectinate muscles all the way around the atrioventricular junction, morphologically right atrium, mitral valve, leading into a ventricle with coarse apical trabeculations, morphologically left ventricle. Looking up into the outflow tract of that ventricle, we see the pulmonary valve, and we see very nicely the malalignment gap between the atrial septum due to the wedging of the pulmonary valve and the ventricular septum. And what we see here is we see that the tricuspid valve also has attachments in this dominant morphologically left ventricle. So here we have the situation where there is a degree of straddle and override of the morphologically tricuspid valve. And look how now we get a clue by the location of the anterior interventricular artery. Again, we're dealing with the situation where the aorta is anterior and to the left, and the cut made by Pradeep is showing us the location of the cavity of the right ventricle. And the cavity of the right ventricle, which is the systemic ventricle, is not reaching the apex of the ventricular mass. So this is the situation I referred you to when we have straddling and overriding of the morphologically tricuspid valve. We have hypoplasia of the cavity of the right ventricle. And then when you look there beautifully, you see this straddling, this overriding left atrioventricular junction, guarded by a morphologically tricuspid valve. Again, there is a minimal degree of Ebstein's malformation here, but here you see that the anterosuperior leaflet of the tricuspid valve is straddling through the ventricular septal defect. There is the crest of the muscular ventricular septum. The valve is crossing it to achieve its attachments into the morphologically left ventricle, and because of that, we see the hypoplasia of the morphologically right ventricle. And as more and more of this valve goes into the left ventricle, the more dominant will the left ventricle become, and then eventually we'll end up with double inlet left ventricle, an anterosuperior incomplete right ventricle with discordant ventriculo-arterial connections. So a somewhat bigger heart this time. And I need to open it the right way round. I could tell that was going to be a tricuspid valve because there was a valvar prosthesis in it. So I've reversed the heart so that I can show you the right side first. And again we see very nicely the the morphologically right atrial appendage, pectinate muscles extending all the way round the atrioventricular junction. Henry, I want to get the screen full of blue so that we don't get nasty bits extraneously. So there you see the pectinate muscles, again morphologically mitral valve, morphologically mitral valve leading into a morphologically left ventricle, arising from the morphologically left ventricle, the pulmonary trunk. The pulmonary trunk branching into its right and left branches. Again, intact septal structures. And this is the end stage of Ebstranoid degree of the tricuspid valve. Because this time the valve was removed and has been replaced with a prosthesis. So there you see the valvar prosthesis. We can't see the remnant anymore of the morphologically tricuspid valve, but what we can see very nicely is left-handed ventricular topology. My thumb goes towards the prosthesis, my fingers up the outlet. There is the aorta that is arising from the outlet of the morphologically right ventricle. In this instance, maybe we have a solitary coronary artery. I can see. Oh, the two. I can see one there, and I think there might be two orifices arising. So there we are. There are two coronary arteries, but they are arising from the same sinus. So here the right coronary artery is going to run behind the aortic root to reach the left-sided atrioventricular groove. That will be the stem of the main stem of the left coronary artery, and they're arising from the left-handed sinus, sinus number 1. And this is the frequent lesion that we see in congenitally corrected transposition. And another surprise for me. So goodness knows what we're going to find this time. So, morphologically right atrial appendage, pectinate muscles all the way around the atrioventricular junction, a small ventricular chamber which is a morphologically right ventricle. I think there might be possibly a minimal degree of detachment there of the septal leaflet away from the atrioventricular junction. This is so-called Micro-Epstein's malformation. I think you can see the line there. That is the atrioventricular junction, and there's minimal displacement of the septal leaflet. So this is the sort of thing that oftentimes we see in pulmonary atresia with intact ventricular septum. But this time we certainly don't have an intact ventricular septum. We have arising from the morphologically right ventricle an arterial trunk, which gives rise to brachiocephalic vessels, I think, or is it? No. No, sorry, I take that back. There are spiraling arterial trunks. The brachiocephalic vessels are arising from this vessel. So this, in fact, is the pulmonary trunk. And there we have a ventricular septal defect, which is a directly subarterial, juxta-arterial ventricular septal defect. This is the so-called supracristal variant. Posterior inferiorly we have this muscle bar, which is the caudal limb of the septomarginal trabeculation. So the defect is opening into the right ventricle between the limbs of the septomarginal trabeculation. And what you can see is that the pulmonary trunk is in part overriding the ventricular septum and has part of its origin within the morphologically left ventricle. So if we open out now and we look in, we can see very nicely now that there is caudal displacement of this structure. If I go back and look again, that is the structure that is caudally displaced. So in fact I was wrong when I implied that this was a doubly committed defect. In fact, that is the outlet septum that is deviated posteriorly into the left ventricle. So there we see posterior deviation of the outlet septum, a muscular outlet septum. So we see rather nicely here now the overriding of the pulmonary trunk. And here the posteriorly deviated outlet septum has now crowded the left ventricular outflow tract. The left ventricular outflow tract is the aorta. Smooth septal surface, very nicely there. You see this is a left ventricle. There is the mitral valve, left atrial appendage, concordant atrioventricular connections, smooth septal surface in the left atrium. So we might now anticipate, because there's obstruction of the left ventricular outflow tract, that there might be coarctation or interruption of the aortic arch. In fact, I think there is a narrowing here within the aortic arch. Although the aortic arch is continuous, there is no interruption of the aortic arch. There's a small arterial duct there. When we look inside, we see that the arterial duct is closed. There is the dimple at the pulmonary end of the arterial duct. Pradeep has not opened the aorta, but rather nicely we can see the branches of the aorta, the brachiocephalic artery, the left common carotid artery, the left subclavian artery, and then there is a very tight coarctation here between the origin of the left subclavian artery and the descending aorta. And I tell a lie, he has in fact opened the aorta, and there you see this coarctation lesion that is at the mouth of the left subclavian artery, and it's the tight ring that is narrowing the junction between the transverse aortic arch and the descending aorta. So a nice heart with caudal deviation of the muscular outlet septum, the caudal deviation obstructing the left ventricular outflow tract, and in association with that, severe aortic coarctation.
Professor Anderson, is there any coronary artery abnormality in the heart you just showed? Or the coronaries arising from the aorta or the arising from the pulmonary artery?
The coronary arteries are arising from the aorta. Pradeep assures me he would have told me if there had been a problem with the coronary arteries. There is a degree of stenosis of the aortic valve, I think. I think that there's a degree of tethering here of the leaflets, but if we... There is one coronary which takes a high origin, and the other origin. We can't see it very well, but Pradeep assures me that they are both there. I've come to take Pradeep's word as gospel, so I think we can depend upon that. So this is the last surprise he's got for me. It's a funny little heart. It's a rather globular heart. I'm not sure I've seen a heart of this shape before. Difficult to see where the ventricular apex is. What we can see is that that is the morphologically right atrial appendage. We open the morphologically right atrial appendage very nicely now. We see we're dealing with a morphologically right atrium, as we'd expect. The oval fossa, which is intact. Morphologically tricuspid valve. We can see very nicely there the septal leaflet of the valve, which is attached to the ventricular surface. And we open up and we find an outflow tract. The outflow tract comes up, and it's leading into a pulmonary trunk. But there is a little hole there in the pulmonary trunk. Is that the left pulmonary artery?
Yes.
That is the left pulmonary artery, the right pulmonary artery?
Yeah.
But that... Yes, it is. Right pulmonary artery. So, thus far, the right side of the heart looks normal. So I wonder why he's showing me this. Let's, what?
This whole here. Yeah.
So that is the aorta. No, that is the pulmonary trunk.
And this is the aorta.
This is the aorta. And so there is a communication between the pulmonary trunk and the aorta.
There's no length.
What sort of communication is it? It's at the margins of the pericardial cavity. The pulmonary trunk is arguably riding the aorta, so I guess this is an aortopulmonary window.
Or whether it is a window ductus.
Or a window duct. Who knows? There's not enough of the heart left, really. We can't see the pericardial cavity. If the pericardial reflections were there, I would expect a window duct to be extrapericardial, whereas I would expect an aortopulmonary window to be intrapericardial. I can't really see the margins of the pericardial cavity anymore.
Yeah, all that is the pericardium.
There is the pericardium. So it is intrapericardial. So it's an aortopulmonary window that hardly has any length. And also the association of the right pulmonary artery with the aortopulmonary window leads me to suggest again, because I think this right pulmonary artery is also connected to the aorta at the margins of the pericardial cavity. So, a distal aortopulmonary window. Okay, there we are.
I think, as Snehal told me, we are going to have the next talk by Dr. Pankaj on the echocardiographic correlation.